Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through the pharmacology for dysrhythmias. A dysrhythmia is an abnormal electrical activity in the heart. When we talk about assessing the heart, there's many different ways to assess the heart. We can assess the output, we can assess the electrical activity, and more. Today, we're focused on the electrical activity. The primary way that we assess this is with an ECG or an electrocardiogram. You may also see this referred to as an EKG, though there is no K in the word. When we talk about dysrhythmias, we're going to call anything other than normal sinus rhythm a dysrhythmia. Some of these can be what we call normal, what we expect to find, and we call these physiologic. On the other hand, this can be as a result of a disease process, and we call this pathologic. An example of a physiologic dysrhythmia would be where someone's exercising and their heart rate goes up, and now they're in sinus tachycardia, and that's expected. On the flip side, we call it pathologic if, let's say, someone has atrial fibrillation, where they have an abnormal heart rhythm, and that's disease-related, that's called pathologic. The way we diagnose dysrhythmias, and again, I'm not going to go too deep into this since this is pharmacology, but we diagnosed it based on an ECG. Almost always that would be a 12-lead ECG. We don't really use the 3 or 4 or 5 lead for diagnosis. We use it more for monitoring. We can also do this based on long-term ECG monitoring, such as with a Holter monitor. Symptoms of a dysrhythmia can be all over the place because there's so many different dysrhythmias. However, the most common things that you would see certainly on an exam would be things like palpitations, near syncope, where the person feels like they're going to pass out, dizziness, or in most cases, they're completely asymptomatic. In a dysrhythmia that impairs perfusion, specifically atrial fibrillation, these patients are almost always going to also be put on an anticoagulant. And that's an important pharmacology point to know and certainly fair game for a nursing school test. Let me take 2 seconds and explain why. When we have a dysrhythmia that impairs perfusion, that means that blood is not flowing properly. When blood is flowing properly, we have a minimal risk of developing a clot. However, when blood is flowing improperly, we have impaired perfusion, the risk of a clot goes through the roof because now the blood, instead of constantly flowing smoothly, now it's getting bumped and jostled around, and it has time to pull up a chair and bump into a corner and sit up for a while or sit there for a while, and now we have a clot. So for that reason, anyone who has a dysrhythmia that impairs perfusion, such as atrial fibrillation, is almost always going to get put on an anticoagulant in addition to their antiarrhythmic. I do want to make one last point before we go into discussing all the different medications. All antiarrhythmics, or almost all antiarrhythmics, carry a risk of causing dysrhythmias, which makes sense. If I'm giving you a medication that's going to mess with your heart rhythm, it also has a chance of messing with your heart rhythm. Just because I'm giving it for a positive effect doesn't mean it won't have a negative effect. That being said, obviously the risk versus reward is almost always there, which is why we use these drugs. So the primary medications that we use to treat dysrhythmias are divided into 4 classes, class 1, 2, 3, and 4. Now, all 4 of these have one major point in common. These are all inhibitors or blockers, which is essentially the same thing in pharmacology. And if you think about what is a dysrhythm, if you had to put a dysrhythm into a word, you would say that dysrhythm is hyperactivity. Obviously, a more correct word would be abnormal activity, but let's think of it as hyperactivity of the electrical cells of the heart. So if I have the electrical cells being hyperactive, being out of control, by me inhibiting or blocking, I'm going to slow things down and I'm going to get them back under control. So that's why all 4 of the drug classes we're about to learn are all inhibitors or blockers of some kind so that they can slow down and calm down the electrical activity of the heart. So let's go ahead and look at the first class of drugs. And one last point I do want to make, just like the fact that they all have the inhibiting and blocking aspect to them, because of that, they pretty much all also slow down a patient's heart rate. So you're going to see bradycardia in pretty much all of these as a known effect to monitor and something that you can also consider a side effect. So let's start with the first one. The class 1 antidysrhythmic medications are sodium channel blockers. Now we divide these into 3 classes, class 1A, 1B, and 1C. So let's start with 1A. The drugs over here are procainamide or others. These medications have a moderate sodium channel blockade, and they work by prolonging the action potential duration. I wouldn't expect at the RN level that you would have to know that exact technical definition. I think that's probably more NP or MD level. But basically, for all of these, you have to understand the sodium channel blockers block sodium channels, which slow down the conduction throughout the heart, which reduces the effects of the dysrhythmia. What do we use this for? Class 1A are used for supraventricular rhythms, such as atrial fibrillation, as well as ventricular rhythm. Those are 2 kinds. We have supraventricular, coming from above the ventricles, aka the atrium, or the ventricles themselves, which would be ventricular rhythms. The side effects and adverse effects of these drugs include diarrhea and cardiotoxicity. And the class 1A antiarrhythmics have a black box warning, multiple of them. One is that they can cause lupus-like syndrome, One is that they can cause blood issues, and one is, like we already said, that it can cause dysrhythmias, which is going to be common to almost all of these. Next, we move on to the class 1B antiarrhythmics. These are still sodium channel blockers, but this one is lidocaine. This one, again, is obviously going to have the same mechanism of action, just with some small, minute differences. Again, I wouldn't harp too much on those at the RN level. These medications are used for ventricular arrhythmias, not supraventricular arrhythmias. And the most common adverse effects, certainly the most tested on one that I've seen in test banks, are CNS effects, such as dizziness and different neurological symptoms like that. Next, we have that these medications are contraindicated in patients that have Wolff-Parkinson's-White, that's a specific type of dysrhythmia, as well as certain heart blocks. Lidocaine is also very famously used as an anesthetic, such as when we're going to give sutures to someone, or Novocaine if you're getting a dental procedure. Next, we have drug class 1C antiarrhythmics. These are still sodium channel blockers. These are some of the newer ones, like propanone, that are also used to treat dysrhythmias. Again, these block sodium channels, and you can look over here at the specific ways that it does that. Again, I wouldn't harp on that. What do we use these for? These are supraventricular rhythms, but these should not be used in patients who have a structural issue with their heart, a structural heart disease. And again, it has the same black box warning that we saw previously, that it has the proarrhythmic effects, that it has a risk of developing an arrhythmia. Now, the next black box warning says consideration for increased mortality. Let me explain that if you haven't seen this before. Consideration for increased mortality means as follows. If I give a patient a medication for let's say for low blood pressure, and it brings their blood pressure up 120/80, yay, I'm so proud of myself, I did a great job. But if we look at the data, and the data says that out of all the patients that got this versus out of all the patients that did it, at the 30-day mark or at the 1-year mark, whatever it is, but let's use the 30-day mark, if at that point they still died at the exact same rate if I wouldn't have given the medication, then did I really do them any good? So again, back to what I just said. If I gave a patient a medication because their blood pressure is super low and it brought their blood pressure up to 120/80, but we look ahead at every patient who got this and every patient who didn't get it or got alternative treatments, and none of them had any better survival, then did I really help them? So the same thing over here, these drugs have a black box warning. That data shows that there's really no benefit in survival with these patients. So strongly consider if you want to use this medication. Again, that's above the RN level, but since it's a black box warning, it's certainly fair game for your tests. Next, we have the class 2 antidysrhythmics, and these are the beta blockers that we've seen over and over again. The drugs we're talking about here are propranolol, metoprolol, atenolol, etc. All of the very famous LOL drugs. How do these drugs work? They block the beta-1 receptors. Beta-1 stimulates the heart to beat faster and harder and stronger. So this is going to make it beat less fast, less hard, and less strong. It reduces chronotropy, it reduces inotropy, and it reduces that excessive stimulation of the heart that is what's causing it to go haywire. What do we use this for? We've seen this so many times, especially if you're just in the middle of our cardiac pharmacology series. We saw this for angina. We saw this for hypertension, where it's also coming up, if you haven't seen yet, the heart failure lecture. We also use this for migraine prevention, for anxiety, for a bunch of different things. When we're using it for arrhythmias, which is what we're talking about today, we use it for atrial fibrillation. We also use it for atrial flutter. The adverse effects of these, again, we've listed these over and over: fatigue, bradycardia, hypotension, all of those things. And it does have that black box warning that we've said in the past, that you shouldn't suddenly stop taking this drug because it supports the functions in the heart. If I suddenly stop taking and the heart suddenly loses that support, it's not going to go well for the patient. Also, if you're giving the patient a non-selective beta blocker, then be careful if they have an underlying pulmonary condition or an active current pulmonary condition. Again, this is just something that you should note that it may be an issue. Obviously, we're not prescribers at the RN level, so that's not going to be an issue. But it is something that your test can ask you. When would you, I don't know exactly the wording to expect, but something like when would you challenge an order, or not really challenge, but when would you double check an order? Next, we have the class 3 antiarrhythmics. These are the potassium blockers. This is amiodarone. Amiodarone is very, very popular. It works by prolonging repolarization, and by making the repolarization longer, it slows down the electrical activity of the heart. We use this for arrhythmias. We use it, it's labeled for ventricular arrhythmias, but it's primarily used for atrial fibrillation, which is actually an off-label use. So this medication has a bunch of side effects: bradycardia, hypotension, dysrhythmias. We talked about that with all of them. It does have 3 black box warnings. It can cause pulmonary toxicity, so lung issues. So make sure you're monitoring the lungs in any of these patients, and that's fair game for your test of which of the following patients or which of the following drugs would need you to check, I don't know, lung sounds maybe. It would be a patient taking this to monitor for that pulmonary toxicity, plus hepatotoxicity. And again, we talked about that one in the past, check their AST, ALT, things like that. This medication is not considered safe in pregnancy. This is one of the most popular medications for atrial fibrillation today. And this medication, they need to avoid grapefruit juice because it can cause medication toxicity. I don't often mention that in these lectures because it's so common in pharmacology. But since this is a very much tested on drug, there's a lot to know about it. I would go ahead and I would commit that to memory. This medication is very interesting because it has one of the longest durations in all of pharmacology. Even though it's a daily medication, it does last in our system for up to about 1 to 2 months, depending on the patient, but up to 2 months it can last in our system. Very, very long duration. We don't often see that in pharmacology. Usually we're talking hours to days. Next, we have our class 4 antiarrhythmics. These are our calcium channel blockers. We've seen these in the past. If you've seen in migraine prevention, this was mentioned in angina prevention. This was mentioned in hypertension. When we're talking about the class 4 antiarrhythmics, calcium channel blockers, we're talking specifically the non-dihydropyridine. If you watched previous lectures, such as hypertension, you noted that we do have dihydropyridine and non-dihydropyridine, two subclasses of calcium channel blockers. For dysrhythmias, we're specifically talking the non-dihydropyridine. The drugs over here are verapamil and diltiazem, and these work by relaxing the vascular smooth muscle. And by relaxing the smooth muscle, that causes vasodilation, and it decreases the cellular excitability of the cardiac cell's electrical activity. What do we use this for? We use this for a bunch of things. Today we're talking about arrhythmia, so I listed that first, and specifically atrial fibrillation, atrial flutter, and PSVT. If you don't know what PSVT is, it's paroxysmal supraventricular tachycardia. It's a condition where a patient has certain cells in their heart that start firing at a massively fast rate, and their heart rate will literally randomly go from a normal 60, 70, 80 way up to 150, 170, 180 all of a sudden. So most of the time the patients have triggers. It could be stress, it could be caffeine, but these cells, these cardiac cells that are doing that are the problem. And we very often treat them with medication, or we could treat them with what's called cardiac ablation. We're not going to talk about that today. The side effect of these medications, once again, we have dysrhythmias, and I am specifying here in writing that we're talking the non-dihydropyridine only. Next, we have our drug class cardiac glycosides. We're going to talk more about this in the heart failure lecture because this is really not used very much for dysrhythmias. But the drug we're talking about here is digoxin. Digoxin works by increasing the effects of calcium, which result in increased contractility. That's how it helps for heart failure. It works slightly differently for dysrhythmias, but I'm not going to get into that over here. The indications that we have for this drug are dysrhythmias such as AFib and aflutter, and like I said, it's also used for heart failure. Overall, this drug is not used excessively for a number of different reasons. First of all, it's not used excessively because it has a narrow therapeutic index, and you should remember that anytime you hear narrow therapeutic index, that means that patient's going to need lab monitoring very often in order to make sure that the patient's medication level is within normal limits. This does have a bunch of side effects, including nausea and vomiting, which tons of medications have. It can also cause visual disturbances, bradycardia, and dysrhythmias. The visual disturbances, I've seen this on a bunch of test banks, so I did specifically write it down here. It can cause halos around lights, which is where you see, basically, if you don't have good vision, or if you're someone who wears contacts or glasses, if you don't have that in, all the lights look like they have halos around them. That can come from digoxin toxicity, where a patient has too much digoxin. Patients should have their heart rate, their digoxin level, their ECG, all of that monitored when we're treating a patient for their dysrhythmia. We do have an antidote available if a patient becomes dig toxic, is what it's called, digoxin toxicity, and that is digoxin immune fab. Next, we have a drug called adenosine. Adenosine is different than everything else we covered so far. Adenosine is ATP, adenosine triphosphate. Hopefully all of you remember that from your anatomy and physiology course or basic biology, but ATP is the energy of the cells. So this drug, adenosine, is literally just ATP. And what do we use this for? We use it for one thing. We use it for when a patient has a super fast rhythm, SVT, supraventricular tachycardia, and we do it to slow down their heart rate. How does it work? Very simple. If I give a patient a ton of ATP, that's free energy. To us, that's free money. The cells stop whatever they're doing, just like we would if someone was throwing around free money. And all the cells stop what they're doing and start gobbling up and grabbing every drop of that ATP. So when I go ahead and I inject the patient with ATP, the cells are going to instantly stop what they're doing and start grabbing it. And then as soon as they're done, which this is done in seconds, the cells go back to their normal function. So here's the way it works. A patient has a super fast heart rate, SVT, and it's going at 180 beats per minute. They come into the ER. Let's say they're having maybe some mild chest pain or palpitations or whatever it is, but they're otherwise stable, because if they're unstable, we're going to treat them with cardioversion. And we're not going to discuss that any further. But if they're stable, we're going to treat them with adenosine, at least to start. So what's it going to do? We're going to give the medication. And when we give the medication, the heart's going to literally stop what it's doing. It's going to start beating. It's going to stop the electrical activity. It's going to start gobbling up all of that ATP. The second all the ATP is gone, it's going to go back to business as normal. The concept being that hopefully business as normal, it goes back to starting up at a normal heart rate of 60, 70, 80, not back to the 180 or wherever the patient was at previously. That's the concept behind this medication. There's a bunch of things to know about this, although surprisingly, this is not very much tested on, at least in the nursing test banks that I reviewed for these videos. Now, a few things. Patients who are given this medication must be on a cardiac monitor, and they should have an ECG continually printing or saved to your system while you're giving this medication before and after. When we give this medication, I don't know the exact statistics, but I've given it hundreds of times. I'm also a paramedic. And when we give this medication, roughly half the time in my experience, it works. The patient's heart rate stops the 180, it flatlines for a few seconds, then it goes back and it starts at a normal rhythm. However, about half the time, excuse me, it starts back at that 60, 70, but within 5 seconds, it's right back up to the 180 beats per minute. So in that case, did I really gain anything? And the answer is yes, because we don't only use this to treat, we also use it diagnostically. When a patient's heart rate is beating along at 180 beats per minute, I can't really see what's in that PQRST complex. And there's so much that we get to learn from that. So if I slow down the heart rate, even if it's just for a few beats, I do get to see what their underlying PQRST looks like when it's not at 180 beats per minute, when it's only at 80. And now I'll actually have additional information, even though the medication didn't successfully keep the patient's heart rate down. So again, a whole bunch to know about it. When we're giving this medication, we always want to give it as centrally as possible, meaning in an AC or even in an EJ or IJ, because this medication is going to be gone in seconds. This medication lasts for less than 10 seconds, again, because every cell in the body is gobbling it up. It's free energy. So because it's given, it goes away so fast, we always want to give it as centrally as possible so that the heart is actually the one that gets to gobble it up so that it works. If we have like an IO or something, that's going to be very less ideal to give it, but we can still do that. When we're giving this medication, I don't ever cover dosages because that's rarely ever on the NCLEX, but this is a very famous one, so I did throw it in here. I don't know if I would actually study that for an RN level exam, but I did put it on here. It's usually given 6 milligrams, and then if we're repeating it, we could repeat it at 12 milligrams or a repeat of 6 and then another 12 or some variation of that, but 6 and 12 are the two most common dosages, 6 being the first and 12 being the follow-up. When we're giving this medication, you must educate the patient that they are going to feel extreme discomfort. They're going to feel a sense of impending doom because their heart is literally going to stop beating for about 5 to 10 seconds, which it's never done in their entire life, hopefully, because then their life is over. So do let them know that. Make sure, generally speaking, we always put pads on these patients, the AED pads. I know that can freak patients out, but there should already be some level of concern that their heart rate's 180 or 240 or whatever it is. But we do go ahead and put the pads on this patient in case it has that one-off chance that it completely stops the heart and the heart doesn't start back up again. We could shock it back. And this is also known as chemical cardioversion. You did hear me briefly mention that when we give this medication to stable patients, if the patient's unstable, they would actually get electrically cardioverted. This is referred to as chemical cardioversion. Next, let's go just a few last notes and then we'll wrap this lecture up. Electrical treatment of the heart includes cardioversion. Cardioversion is synchronized shock, and we use that for tachydysrhythmias, most commonly for SVT. We don't use it a whole lot for AFib. Defibrillation is another type of shock that we use for dysrhythmias. This is an unsynchronized shock, and this is given for life-threatening dysrhythmias, such as ventricular fibrillation or ventricular tachycardia. And finally, another electrical component we can have is pacemaker implantation, and that's where we go into the lab and we put a pacemaker inside the patient in order to have that available for the patient to maintain that electrical stimulation for electrical activity in the heart. I don't know how deep into a pharmacology course will go into these electrical notes, so I just put them here just so that you have them FYI. Other things that we have are ICDs. I mentioned cardioablation very briefly. I'm not going to go further into it than that. I do want to mention that magnesium and other electrolytes can be the cause and or the treatment of dysrhythmias. If a patient has, let's say, dysrhythmias along with hyperkalemia, they may get treated with calcium. If a patient has hyperkalemia, they can have an abnormal cardiac rhythm. So a lot of the electrolytes can cause or be part of the treatment for these dysrhythmias. So again, I'm going to let your professor, if you're in school, go into detail on how much they want to get into with that. But we do also discuss this a little bit more in the food and electrolyte lecture if you haven't already seen that. And finally, any patient with a dysrhythmia or being started on an antiarrhythmic medication always needs to be on a cardiac monitor. If you have any questions, please reach out. Please subscribe to our channel and have a great day.